what we do, and it'll be great to hear from you, Nader.
Thanks, Boo. And just to add my thanks for organising today, it's been really fantastic. Thank you. I suppose, like Professor Lovett, I'd like to say I'm pretty glad to be bringing something a little bit different to this. My perspective on what I'm going to be talking about today really is a patient and a technologist perspective, hence the slightly ostentatious title of my presentation. So I suppose, and most often when I speak to people about this, they don't know much about what I'm talking about, so you guys are going to have to bear with me while I go through the rituals, as it were. Fundamentally, the issue that we've been looking at over the last 3 or 4 years is the mismatch between the way that disease progression takes place and the way that care is delivered. Fundamentally, you have a disease that's characterized, this is, I mean, inflammatory conditions generally, but IBD in the context of this discussion, characterized by, I suppose, unpredictable cycles of wellness and then poorliness, whereas care is delivered in a linear and episodic way. And so what we see is, I don't know where I'm supposed to be pointing this, but I'm going to point it somewhere and hope that something happens. Oh, wow. A lot of slides are showing up. Okay. What we see is that fundamentally, above the line, during periods of remission, patients are looking to build resilience, to build a better understanding of what it is that's wrong with them, and to build strategies for staying well. Obviously, as the condition deteriorates, one of the key markers of how things are going to progress is how quickly they get access to care. And of course, one of the things that we're looking to do over time is to actually teach people how to manage their conditions in a way and to support them out of hospital in a way that actually allows them to, if not avoid relapse, then at the very least minimize its effect on day-to-day life. So our approach is pretty straightforward. It's patient-centric, as you would expect. Fundamentally, we look at improving disease knowledge and increasing patient activation through education and tracking. We look at promoting self-care using evidence-based therapeutic programs, and I'll talk a little bit about those in a moment. We look a little bit at how timely nurse-led interventions can actually help patients get themselves back on their feet and also avoid unnecessary hospitalization. I mean, I'm happy to talk a little bit about some of the studies that we've done that have shown that actually people using our intervention show up at A&E 47% less than patients who aren't using our intervention. And that's not because we've solved the problem, it's because health anxiety is what drives a lot of people to show up at A&E when they potentially don't need to. The last piece, of course, is around embedding good practice in people's lives. And, we all have really good intentions, right? Somebody says, this is something that you should do to stay well, and we think, yeah, great, we'll do that. But in reality, building that into your day-to-day life is not as straightforward as it would otherwise appear. And I have a friend who recently became a health coach, and I mean, my initial reaction was, it's quite hocus pocus. But what I discovered, really, or what I've learned, is that the role of the health coach is not really to teach you things you didn't know, but to help you to embed things that you do know into your routine day-to-day practice. So I guess just to talk a little bit about the intervention, I guess Lisa, who has been so wonderful to us, was saying earlier on about how there's a need to kind of coalesce people and innovators around a set of specific and kind of uniform guidelines and guidance and so on and so forth. I buy that, but I also, taking a patient perspective on things, I know that there's no standard that I look for when I wonder whether Google is processing my photos in a legitimate way. Same with dozens of other apps that I use that employ artificial intelligence. And from a patient perspective, I think it's great that the NHS is doing a lot of things to kind of manifest safety and manifest improvement and so on and so forth. But actually, really, what I'm looking for is how many stars does it have in the App Store? Is it something that is well accepted by my peers? Do patients say it's a great thing? So even though I've put there, obviously, we are CE marked, we're a regulated medical device, we've jumped through every hoop that you could possibly imagine. The thing that we're really proudest of is that we have a 5-star rating on iTunes. That's really, where it is for us. So Boo asked me to talk a little bit about what we're doing in AI. I should say, having sat here all day, my imposter syndrome has just completely overwhelmed me. But I will just speak a little to what we are doing. I suppose with 15,000 patients, you can imagine we're accruing quite a lot of data. That data comes in a lot of different formats. Some of the things that we obviously have are the patient-held record, symptom scores, behavioral data, analytics about the ways that people are interacting with our platform. In some situations, we have EPR integrations, and in other situations, we're actually using the NICE guidance to automate routine parts of clinical practice. I suppose the place probably that I would ideally like to focus on is in respect of what we do for people in remission. There is a lot of talk, obviously, about, I suppose, how AI can improve escalation and can help people to, or at-risk people to be better identified. Certainly, that's something that we're working on. But really, for us, when we think about how AI can help patients to stay well and stay out of hospital, a lot of it is about personalizing their care and personalizing their pathway. We do that, basically, and I haven't explained this, but to say we work with experts in diet, activity, sleep, stress management, medical adherence, a whole range of different kind of lifestyle sort of components of staying well, if you like, to develop these kind of wellness programs is the only way that I could really put it. So you might sign up to our app, sign up within it to a 7, 14, 28-day behavior change program using accepted behavior change techniques, which deliver you daily content that teaches you what to do, gives you exercises that let you embed what you've learned into day-to-day life, and then basically check back on you to make sure you're actually doing those things. Now, I guess it goes without saying, there is, at the most generic level, these programs are identical, but where we see the opportunity is to understand a little bit more about our patients, where they fit into different cohorts, how we can analyze the right fit between lifestyle change and the individual, because at the end of the day, and I know there's probably the majority of this room thinks that the most important thing, and this is probably true, is to stay on your medication because it deals with your symptoms. But really, that's a disempowering way to look at disease. So really what we're trying to say is, how do you take control of things yourself? And so, sometimes it's about diet. My wife, who has ulcerative colitis, has managed her disease and put herself into relatively long-term remission just by cutting food out, actually Simon will be better positioned to talk about the stuff than me, but fundamentally cutting out certain elements of her diet, and that's worked for her. But when she used our sleep improvement program, we saw no benefit at all. So different things are going to work for different people, and what we see is an opportunity to take this big data set, and at the moment, our 15,000 patients have probably generated 500,000 data points, something like that. So, we have the basis for building out certain personalization algorithms that can help. I suppose it would be unwise of me to say nothing about clinical practice. I mean, I work with a lot of nurses who identify admin as being the thing that gets in the way of what they really want to be doing, which is looking after their patients. And so we've been working for the last sort of 3 or 4 months with Boo, with other experts, to understand how we can codify the NICE guidance and how we can basically start to automate routine parts of clinical care based on the cohorts that people fit into. I mean, it's things as simple as if you're an ulcerative colitis patient, you're on 5 ASAs, you have a certain pathway that can be automated pretty straightforwardly. That can take, as we've found, that can actually allow a nurse to be 2.5 times as productive as he or she would otherwise be. And actually, the most important thing is that by automating parts of clinical practice, we're able to also start to increase the volume of contact, or the volume of perceived contact that a patient is receiving. It will be no surprise to anybody, the patients that do best with our programs are actually the ones whose clinicians are most actively involved in what's going on. There's a sense of accountability, there's a sense of kind of, I suppose, belonging and direction that you get when that's the case. And so for us, being able to automate a large part of that interactivity actually allows us to increase the warm, fuzzy feeling that patients get as well. I think that's probably all I have to say. Yeah, thanks very much.
Thanks very much, John.
Thank you.